I'm Cristel de la Cruz from Lundbeck Philippines Inc., organizer of this online exchange forum, and I will be your host in this live webinar. To formally open tonight's learning session, allow me to introduce our speaker and moderator, Dr. Helen Santiago Sigua. Dr. Sigua was a cum laude graduate of BS Psychology from the University of the Philippines. She was also a graduate with a scholarship grantee in Behavioral Science and Family Systems Educator Fellowship in USA in 2012. Also a graduate with a scholarship grantee in Leadership in Mental Health at the American University in Cairo, Egypt in 2019. Also a graduate with a scholarship grantee in Leadership in Mental Health Human Rights Law in India in 2020. Dr. Sigua was also a graduate of Doctor of Communication from the University of the Philippines from 2017 to 2020. She is also the medical director and the physician at God's Touch Family Clinic and Life Touch Medical and Inspirational. Dr. Sigua is also a medical specialist 3 at the Department of Health from 2018 to 2019. She's a technical expert at the Center for Excellence in Primary Care at Regions 2, 8, and 7 at the European Union DOH Policy Bureau in 2018. She's the current chair at the Mental Health Committee and Life Fellow of the Philippine Academy of Family Physicians from 2018. Please join me in welcoming Dr. Helen Santiago Sigua. You may share your screen, Dr. Sigua.
Can you see my screen already?
Yes, doctor.
Okay, so, okay, good evening. Good evening, everyone. So, is that clear already? And can you hear me?
Yes, doctor.
Okay. So, okay, I welcome everyone for this series of workshop. Actually, we have started the first one last year, also with Lundbeck Philippines, and that workshop was some sort of filling the pulse. We invited about eight speakers, a mixture of private and government, and a mixture of family physicians and neurologists, psychiatrists, and even allied professionals, so that it became a sort of validation of our trajectory to helping capacitate our health care towards quality mental health. Okay, we know that mental health is a very relevant field now. Okay, if there's one good thing that the pandemic brought, was that it brought forth the relevance of mental health in whole of person health and whole of society approach. Do you agree with that? Because that's why even in our title it says navigating collaborative mental health care across the family life cycle, because we want to have a common language that will be found comfortable to use across disciplines, and something that should be trans-pandemic and beyond. Okay, so we know that so many things changed. in a drastic way. And that's the reason why we are coming up with a, a capacity building material like this that is formal, that can be used in all levels across disciplines. And we would like to thank our participants as well as our speakers and our sponsors to making this a possibility. As chair of the Mental Health Committee of the Philippine Academy of Family Physicians, this has been a long time dream. And after my training abroad and locally, working with several institutions and organizations on mental health, and now at the season of my career, zeroing in into mental health, I found that this is very relevant and meaningful. Okay, so please stay tuned. But before we listen to our esteemed speakers, I would like to give you an overview of what we are going to have. Okay, so the last time we had a workshop, I think the key points that were stressed there was that number one, now that we are given the policy, the legal framework, no, with the Philippine Mental Health Act law, we have to develop the implementing rules, okay, and regulations. And with that should go the clinical guidelines, the protocols that should be observed so that the collaboration, the delivery of services will be coordinated, and that the health professionals in different levels would know their different positions, their different roles. And of course, that's a long shot. We know that. We know that. But we have to start somewhere. And that's what we are accomplishing now, which is putting everyone at the same page, um, explaining the basic principles that should govern our task sharing. All right. And that's why even WHO, all right, um, we start with a very laymanized way of defining what mental health is, so that we can level the field, no, the playing field. Well, mental health is defined by WHO as a state of well-being in which every individual realizes his or her potential, can cope with the normal stresses of life, can work productively and fruitfully, and can make a contribution to her or his community. So, regardless of the handicap, okay, so we are in a very imperfect world, and many times we have flaws, okay, biomedically, psychosocially, but then we can still be functional with the help of one another. And the word normal is now changed, like we are into a new normal right now. Our behaviors are required to adapt to that new normal so that we can survive and thrive. Not only survive, but thrive. So when you say thrive, you speak of quality, right? So given that, um, it's 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 the life course approach. Okay, the life course approach is a broader framework than what we are using in family medicine, but it resonates, no, because it is a developmental approach. It is a progressive, no, it's basic. So it is described by certain principles of health development, of unfolding, of complexity, okay, timing, plasticity, thriving, and harmony. So it is, from these words we can see that it's something organic and systemic. Right? It integrates the concepts of health and processes that are integrated and interrelated with a unified whole. And therefore, the very negatively perceived fragmentation of the person, of the sick person in healthcare is slowly putting back together again. Okay. So with the awareness of mental health, with a greater awareness of mental health related to the physical, then we are integrating the person back again. The way the person should be. And therefore it is characterized by unfolding, by a continuous process, a continuum, a spectrum. And therefore, our services must also be in a spectrum. No? We should be able to address. Ngayon, ang daming gaps, no? From the spectrum of prevention, promotion, prevention, curative, and rehabilitative, maraming hindi na-address. And therefore, we in the family medicine find it very probably strategic to be at the middle. No, we are in the middle ground to leverage both sides, no, the specialties and the allied professions, so that we as a team would know our respective roles and who would be able to address the needs of our patients and the community. And it is definitely, the human person is a very complex entity. But the complexity, the multidimensionality makes it more adaptive than other organisms. Okay, that's what differentiates us from animals. So we can be very resilient, no? We have mind, we have the spiritual level as well, okay? That's why we can transcend. And of course, our bodily, our physical immune system. So when you talk of immune system, I think at the level of the mental health, we speak about it as mental resilience, right? And therefore, that's the aspect that the family medicine also focuses on. As psychiatrists, focus on the curative aspect, the a different micro level of care. Okay, but we all doctors and all health professionals should be knowledgeable about these general principles, right? So also health development. When you talk of health as a developmental process, it talks about malleability. No? There is a plasticity or flexibility that enables us to hurdle shocks and stresses that we confront. It says there in the WHO, stresses are normal. No? Parang part na yan ng life talaga. I think in the living system, it is very normal that a living organism is always day in, day out subjected to challenges, no, to shocks and trauma and everything that although there's some permanence or constants, mayroong laging change na kailangan tayong mag-adapt in order to get back to homeostasis, to equilibrium, no? So thriving is all about that. Okay, it protects us from not only physical disease but mental handicaps. And of course, the goal would be harmony and balance, no? To balance all these dimensions, the biomedical, molecular, physiological, behavioral, and at the higher, the cultural and social, political context. And then, of course, we know that we go through eras, no? We are progressive. We are always changing and developing and evolving. There's always growth, right? So that's what we want to you to be aware, the life course approach, and that is adopted by the WHO and the UN themselves. So also what I want also you to be aware of are the three levels of healthcare support that we give. No? When we talk about mental health, before akala lang natin micro macro no ang context. Okay. The person is in the middle. When you go micro, you talk about the cellular, the molecular, physiologic. And when you go psychic, you talk about psychiatric disorders and other mental health issues. When you talk about macro, we can further subdivide this. There's another level, the middle level, which is the meso. Okay. So when you define these levels, macro refers to historical and societal influences. When you talk about meso, you talk about parent-child relationship, family environment, socioeconomic status. And when you talk about micro, of course, nandiyan na rin yung biophysical as well as the cognitive, the emotional, the personality, and even genetic factors that would determine certain predispositions to uh, neuro, neurologic deficits. Okay, so we see that we have all parts to play here, even the non-health. No, even the non-health, we have to network with them to be able to deliver the kind of support that is due to our mental health, to our patients with mental health issues. And sa family medicine, of course, right now we have to focus on the emerging adult, okay? And specifically, the second order changes or adaptive behavior or goals, developmental goals that we want to accomplish here is yung differentiation of self, okay, in relation to others, specifically the closest unit, which is the family and the community, the workplace, the school, okay, and development of intimate relationships, no, not necessarily marriage, but maybe just plain friendships, and establishment of self in work, and therefore financial independence follows. So these are the basic developmental changes that we want to goal in this. So at this point, bakit ba nagiging mahirap maging adult, no? As in, yan, naririnig natin yung word na adulting, no? And merong term pa na emerging adulthood. As if that process becomes prolonged, okay? And dati earlier than age 24, but now about 75% of adults enter this phase at the age of 24, and probably it becomes even pushed at a later age. So it's a socially constructed process determined by generic and also sociocultural factors. And makikita natin na ang drastic macro level upheavals na nangyari to affect this phase is first of all yung industrialization. Okay, so nagkaroon ng maraming changes, marami ng options ang isang adult, no, to go through other than marriage, other than reproduction, no. And also the second macro level upheaval is the digitalization. Okay, so here we get into the landscape of communication and interaction is very much widened. The learning, the information, and therefore decision making, no, is largely made more complicated because of the number of choices na options na nagkakaroon ng isang adult. And currently, I think the last major upheaval is this pandemic. And what goes after. So there is prolongation of identity exploration. Okay. And they say that the best indicator for this is self-identity and balancing this self-identity. No? And the top three indicators would be accepting responsibility for oneself, making independent decisions, and assuming financial independence. So the key vulnerable points for adults are usually in the areas of relational boundaries, no? Some are too enmeshed, some are too detached, sense of security, sense of control, validation or approval, acceptance, no? Stability and balance. So if this resonates with Maslow's uh, rules of hierarchy of needs, no? So the one on top would be self-actualization. And for many adults now in our generation, we are very much into actualizing, trying so many things, okay, and proving oneself and one's identity. So what are the major um, macro issues? Okay. Actually, we lack research on this. No, there are basic questions that are really bugging us now, but we see that the this phase is the least um, time na merong control yung yung adult, no, kasi parang yung autonomy niya ang gusto niyang i-pursue and to fulfill and to experiment and explore, okay? But sometimes his or her circumstances would allow that. And so very important, dependent nga din ito, no, itong stage na ito, no, sa earlier stages, the childhood, the adolescence, how well the person went through that. And therefore, when we coach adults, it's very important that we promote empowering strategies towards self-care, okay, the balance of freedom, autonomy with accountability and responsibility. And it is the sense of control, impulse control, and self-regulation needs critical discretion. So now the formation of self is kind of, what do you call this? It's very challenging because merong tinatawag na parang with the advent of social media, okay, kakaroon ng hindi yung actual self kundi yung enhanced self. Minsan, diba? Yung illusion sometimes nagiging na-actualize because of the platform, but and sometimes it can be an expression of maladaptation. So what are the critical elements, okay, of this phase? Sometimes yung mga mental health disorders come, they are more accentuated. They come earlier if this phase is not managed well, because this is the time na nagkakaroon na increase of risk, yung tinatawag na risk behaviors, no? Cigarette smoking, alcohol, drugs, okay, illegal substances. From yung sa cigarette smoking, from 12 to 40% increase. And for alcohol, 11 to 20% increase. Probably more, no? Lalo na sa kultura natin. Early onset and more severe mood disorders correlated with increasing severity. So, ibig sabihin, yung mga mood disorders na experience ay nagiging more severe if this particular phase is has some risk factors to be dealt with. So what's the prevalence of anxiety in particular? Mag-focus tayo ngayon sa anxiety and depression because these are the more common mental health issues in this age, in this phase. And on a general term, we have 10 to 20% of young adults with mental health issues, anxiety from 3%, and it has an upward trend right now. Depression has even as high as 8.1, and it has also an upward trend. And the highest occurrence is in the ages 18 to 29. Okay? Among college students, 41% are with anxiety, 36% with depression. And suicide is the second leading cause of death among age 15 to 24. So this is a global trend. So we can see how serious this problem is. And therefore, akala natin hindi kailangan ng coaching or hindi kailangan ng support ng young adults. And they themselves, they feel they are invincible. No? They feel that they are not at risk, even in getting sick physically and in being susceptible to mental health issues. But that's not true anymore. They are very vulnerable. And not only that, now there are many non-communicable diseases. And the trend now, not only with this age group, the trend now is that depression and anxiety are comorbidities of many non-communicable diseases like asthma, okay, hypertension, okay, even diabetes. We are getting more diabetes nowadays, and even heart failure. Those with congenital heart diseases that progress up to adulthood, and even cancer. Okay, so makikita natin na inano ko lang to because this data comes from psychiatry itself, and therefore even psychiatry and even other fields realize that we should come together in managing, in integrating our services so that it becomes more accessible and more comfortable for our patients and cost effective as well. So that's for the macro influences, macro level. Now for the meso level influences, of course, dito kami papasok, no? Dito yung role ng family medicine talaga. Yung sa macro, more on the public health, okay? But yung sa meso, ito yung family, Ito yung earlier parent-child relationships, na very basic kasi yung trust, yung maternal bonding, yung early maternal bonding is very critical in determining the progression of the succeeding developmental stages. And therefore, certain factors like socioeconomic status, which has indirect impact to level of education, are very critical. But certain studies would show that as a human being, we have a way of making compensatory responses. Kaya hindi mo rin masasabi na porket mahirap, magkakaroon ng immature development or magkakaroon ng mga flaws or defects. Hindi eh. But I think the very basic is the formation of trust. Dito na po form yung socialization, yung early socialization ng isang bata. And this has a lot of impact in the adulthood. So, yun ang gusto kong i-drive at na as physicians and health professionals, we should be sensitive to have a 3D view of our patient, no? Yung longitudinal, yung history niya, pati yung childhood, yung family dynamics, okay? Because this has bearing, okay? Not only in diagnosis, but even in the management, in the therapy. Yung long-term, pag-manage natin sa pasyente, and even them, no, yung self-care nila, because when we listen to them and find these things out, okay, then sila din nagkaka-self-insight. Sila din nagiging aware. Okay, so sometimes you don't have to say anything. No, just listening would make them realize what's going on. That's what you call self-insight. And it's sad lang na karamihan, and this was reflected also in the workshop we had the first time, na a family physician confessed that yon kapos pa rin sila in terms of dealing with the patient, okay, in terms of the of analyzing, not really naman analyzing, but siguro going into the history, the emotional history of patients that are relevant to the present psychodynamics. So, kaya kami nagaganito, no? So that when we make the module, especially the written one, we should be able to tease these things out for you, so that even if you're not psychologist, no, if you didn't have so much background on mental health, magiging aware tayo sa when we encounter and when we interact with our patients. Okay. So sa micro level, specifically, yun nga, of course, nandiyan yung factor ng genetic. Kaya nga kaming physicians, kailangan din tayo from the prenatal, kasi doon nagsisimula yung genetic makeup ng isang tao, no? Getting the nutrition, the ideal nutrition, and the cognitive and the emotional development that will determine IQ and EQ outside the intrauterine life, no, will be determined that early, no, even embryonic development. And as an adult, of course, your identity formation talks about ego identity, behavioral and character repertoire, and social roles. No, so very important that the grounding, the social grounding, ibig sabihin, yung acceptance to no? Yung functionality, yung feeling that nakaka-contribute ka and that you are needed and that you are contributing something to other people is very important, okay, to self. And the critical, so very important, as I said nga, yung processing. Kaya sometimes, pangit, negative yung event, traumatic, but there is some source of higher order coping, or what we call resilience, because of the yung ito rin yung sense making na tinatawag. Ibig sabihin, if there is meaning in the event, attributed to the event, and this is processed according to that individual meaning, therefore, mas nakaka-cope ang isang patient, ang isang tao. Okay, so this is the spiritual aspect. No, it doesn't have to do with a specific religious belief, no, but it's a higher order of coping, of giving hope, of engendering hope, even by self, by a higher being, or by someone who would help that person sort out that meaning. And many times, that meaning, hindi natin maibibigayan. It's only the individual who would sort that out. All we can do is to support and lead the way. Right? And that meaning may be meaningful to that person alone. Okay? We cannot judge it. We cannot give it to himself or do it for himself to realize, but siya mismo dapat ang makarealize. No? And that's a different level of maturity. Another very critical level of maturity is of an adult is ability to delay gratification. Okay, which is kind of threatened at this generation because lahat nga ngayon di boton, 'di ba? So option nito, option nga isang pindot lang makukuha mo na. So ganyan na, no? We see babies knowing how to click, how to, touch the screen, change their options, and therefore, nagbabago na ito ngayon. And we don't know what in the next 5 years, in the next 10 years, this will bring, no? The changes it will bring to adults of the future. So it affects, no, the kind of filtering. So now we are confronted and barraged with all kinds of information, both true and false. And it's so difficult, nakaka-stress na rin to even sort out which is true and which is false. And sometimes it's just a pattern that you just have to deal with, to know. And this is the challenge for an adult, no, to filter out what is short term in pursuit of long term goals or aspirations. And this is the model lang, the framework that is very important sa amin. Okay, when we do counseling, okay, we may not be able to diagnose, come up with specific diagnosis of mental health diseases. But when we do counsel patient or person, it's important that we be able to help that person sort out. And this is the meaning making model. This originates from social science, no, psychology, sociology, and this is being developed now and researched on. Okay, so the meaning or the attribution is based on the appraisal of the event by the person, and therefore it is not only cognitive, it is affective, it is emotional, and yun nga, pwede rin umano din yung spiritual. Okay, so diyan papasok yung worldviews niya, no? Okay, so the interpretation of the event is very important. And therefore, it is a way of coping. What makes sense, no? Because if it doesn't make sense, doon nagkakaroon ng distress ang isang patient. So even if you give all the right medications, but the support, okay, is not meaningful to the patient, and the goal is not meaningful to the patient, therefore, hindi magkakaroon ng fulfillment or fully positive outcome. And sometimes that explains why kahit na mali yung management mo, and sometimes parang nag-click na lang, okay, something turns right, okay? Yun, it's because of that personal, that meaning that is probably sorted out or figured out by the patient with the help of others or singularly. Okay, so ito yung resilience din. No? Resilience in emerging adulthood. This is moving toward resilience. It's a model also of positive change. Now, very resonant with what I've been talking about. And it talks about motivation, opportunities, and strategic executive control. Okay, so when we coach person or adults, whether they have mental health issues or without, okay, whether preventive ka lang or part of a curative regimen, ito yung dapat na you work around with a framework, okay? Because as mentors, no, yung educational part is very important. The non-pharmacologic aspect of management is very important. Counseling, active listening, okay, Huwag niyong kakalimutan yon because yung motivational interviewing natin, yun aligned with this, no? So, you trace out ano ba yung motivation ng pasyente? Ano yung long-term motivation niya? And therefore, this is used even in smoke cessation, okay, and other counseling. Yung mga cognitive behavioral therapy, ito rin ang ginagamit. Okay? So, it has to be developed, yung planfulness, okay? And they have to be able to work this out across school, sa academic nila, endeavors, and even in the workplace. Okay, so as family physicians and public health professionals, allied health professionals, psychiatrists, we should be able to be aware of this. And so, ito yung collaborative care that I would like to traject, no, for all of us. We see here, no, that we should be evidence-based in all levels. Okay, so the primary care, the mental health management can be accessed in the primary care level. So tayo ang first contact physicians, no, even nga yung so the community, even barangay health workers can be capacitated in this framework. Okay, basta i-laymanize lang natin ang ating mga terms because these terms are very universal, no? Universal language. Sabi ko nga, if there's anything that this pandemic brought, anything good, it gave us not only the push for mental health, kasi nakita natin yung relevance, it gave us the language, no? Kasi lahat ngayon marunong na, lahat nag-i-speak na ng comorbidity, no? Or the immunity, yung mga dating medical jargons na iintindihan na ng layman, no? So, we're learning together, learning, unlearning, relearning basic principles. And therefore, pwede pa rin evidence-based yan for as long as we calibrate with each other. Kaya pati research, okay, we should not be only with quantitative forms of research, but qualitative research. And through this, no, we can address the gap of science and service. Right? So, it may not be the ideal. Itong framework na to shows us that the collaboration may be very minimal and it can be full, no? Depending on So ngayon, principles pa lang tayo nagle-level off, di ba? But later on, as we trace out the system, especially with universal healthcare planning, we would be able to put things, medical records, okay, our systems, our referral systems together and look at this. Communication is very important. And what this pandemic brought about is now we can more easily and more conveniently communicate like this. Okay? Hindi na tayo masyadong pupunta sa isang lugar. Ganyan. But now, we know that the skills, the resources can be even put together as we talk to each other. And that's what I like in Kaya itong philosophies and values, whether culturally different tayo, wala yan wala yung differences na yan, no? We, all of us, all human beings have the same goals, no? Yung values natin are very universal, respect, dignity, okay? And no matter how different we are from each other, there's always a common ground. Okay, so, ayun, siguro na ba, I think I will give the floor to other speakers, although briefly, ito lang yung mga strategies, no, that in family medicine, the preventive aspect in all levels, no, preventing onset, preventing complications and quality of life, very strategic. And therefore, the family, even the workplace, no, have immediate roles in detecting problems even during the treatment. of the psychiatrists, and therefore we should be able to work together. Okay, we recognize first the behavioral changes, the signs of relapse, side effects of certain medications, and okay, we can engage with the family, and that's our strength. Teaching the family as a unit for self care of mentally ill patients. So, okay, I think I don't have to go through that. So, planning will be part of giving social support in all levels. Okay. So possible. Actually, this figure is from a journal in psychiatry. And they prove through a meta-analysis, meta-analytic review of certain studies that when they do collaborative care at the level of primary care physicians treating with psychiatrists, especially in areas like our country with so very few psychiatrists to serve so many people. And therefore, this is very important for as long as we are aware of the basic principles. So wherever we are, as a doctor, as an allied professional, as a psychiatrist, as a generalist, we should reject the person. Okay, it should be person-centered, and our goal is to help that person and to be aware, to be self-aware, and to be socially grounded, because that's where the identity and the stability comes from. And we should start with ourselves, right? So with that,
Thank you, Dr. Sigua, for an interesting and informative lecture on navigating collaborative mental health care across family life cycle. Thank you for sharing your time and knowledge. Moving on, please allow me now to introduce our next speaker, Dr. Joan May Perez Rifarial. Dr. Rifarial had her residency training at UPPGH as a chief resident. She also had her fellowship training in consultation liaison psychiatry at Tan Tock Seng Hospital in Singapore. She topped both the written and oral diplomate examination given by the Philippine Board of Psychiatry in 2009 and 2010 respectively, and was conferred as Fellow of the PPA in 2014. In 2016, she served as a member of the Board of Directors of the PPA as a PRO. She's also a mental health advocate and had multiple TV appearances, to name a few, at ABS-CBN, DZMM Teleradio, GMA, DZBB Super Radio, TV5, PTV4, 1PH, and CNN Philippines. She is the Residency Training Officer of the Department of Psychiatry at the Veterans Memorial Medical Center. She's also a faculty member of the Ateneo School of Medicine and Public Health and Health Sciences program of the Ateneo de Manila University. Let us all welcome Dr. Joan May Perez Rifarial.
Hello po to everyone. Good evening to everyone, and thank you very much po, Dr. Helen, ma'am, my boss. Thank you very much po for having me tonight, and of course to all the members of the Philippine Academy of Family Physicians. Maraming salamat, Dr. Helen. Grabe, I was in awe of your very comprehensive introduction and with emphasis on collaboration. Maraming salamat po, Dr. Helen. Of course, hi to Dr. Ed, who is also a speaker later tonight. Yes, so allow me po to share my screen. Maraming salamat po. Ayan! So, I am very grateful. I'm so grateful and thankful po to be with everyone tonight. And I will be giving, from the introduction of Dr. Helen, I will now focus my talk on anxiety and depression in college students, so among college students. All right. So, my clicker is not working. Sorry po. Ayan, so this will be the outline for my discussion tonight. So first, I will just give a very quick overview of depression or MDD, which is the clinical form of depression, major depressive disorder. Second, we will talk about depression and college students. And lastly, treatment of depression following the biopsychosocial approach as mentioned earlier by Dr. Helen. Yes. All right. So first, let's begin with the first part about depression, the overview of depression. It was already mentioned by Dr. Helen earlier that depression, in fact, is a very common illness worldwide. This is according to the World Health Organization, and it is a highly prevalent disorder. It is chronic. It can be recurring and progressive, affecting as many as 300, oh, diba? That's so many, no? 300 to 350 million people worldwide. And according to the WHO, in their fact sheet, number 369, this was reviewed in 2016, depression is the leading cause of disability worldwide. And it's a major contributor to the overall global burden of disease, diba? So global, it's a leading cause of burden. If as shown by this table, it is ranked number 2, diba? Nandiyan, naka-red. Major depressive disorder is the second leading cause of years lived with disability. And unipolar depressive disorders, ito yung it's differentiated from bipolar, which is a mood problem also with 2 poles, kaya it's bipolar, mania and depression. For unipolar depressive disorders, it has depression alone. It's predicted to become the leading cause of burden by 2030. O diba? So this is truly very alarming. Again, just to emphasize the gravity of and the significance of these statistics, the world statistics again, globally, more than 300 million people suffer from depression, and more or less about 260 million suffer from anxiety disorders, and many would have both conditions. It's, of course, later on, I will show you how these two conditions are highly comorbid. So, pwede silang magsabay. They can have an overlap of symptoms. And of course, all of the biopsychosocial understanding for both are more or less similar. And just to give us a clearer picture of how it's affecting us in terms of productivity each year. So these disorders can cost the global economy $1 trillion. Oh my gosh, that's so much, lost productivity each year. All right, so now focusing on depression. Again, this figure shows the different parts of the globe which would have prevalence and shows the prevalence of depression. And of course, we know that the numbers have increased by 18% over the last 10 years and across the lifespan, because we are following the lifespan approach, as mentioned by Dr. Helen, the prevalence of depression has been steadily increasing, and it starts between 3 to 19 years and peaks between 20. So bata, medyo the young adults, 20 and 64 years old. So look at this, from the table, from the photo. Southeast Asia region would have the highest in terms of prevalence of depression around the world. So let's zoom in on this, all right? Yung medyo green color. So depression affects nearly 86 million people in the Southeast Asia region. So if we are to picture it, so parang from the 300 million globally down to Southeast Asia, it's about 86 million in the Southeast Asia region. And what's really important, and we need to be really vigilant about this, is that if left untreated, if we are not able to recognize it and assess it properly, in its most severe form, it can lead to suicide. In fact, studies have shown that in the Southeast Asia region, where the Philippines belong to, suicide is the highest, has the highest, second highest. It's the second highest cause of death among people from the age group of 15 to 29 years. So these would be those in the college years or early adulthood. So Southeast Asia, second leading cause of death is through suicide. Now, diba, like a funnel, so from global, which is 300 million, to Southeast Asia, which is about mga 83, diba, million. Now, let's look at the Philippines, our beloved Philippines. Are Filipinos really one of the happiest people in the world? Do you think so? What do you think? O, di ba? Kasi sabi nila, no, even if there's calamities, any form, no, of mga problems, challenges that our country would face, parang we remain, di ba? We remain pa rin, we are able to smile, we are still able to, to work together, the bayanihan spirit is there. So do you think that as Filipinos, do we have mental health concerns? Studies have shown that in our country, it's about 1 in 5 Filipinos would have some form of mental health problems, and this was reported in 2017 by ABS-CBN. Now, 1 in 5, if you remember from the intro ni Dr. Helen kanina, more or less, diba, if you recall, she gave us a value of mga 10 to 20%. So 20%, parang 1 in 5. And in fact, this was also reflected in a study by one of my mentors from PGH when I was a training resident in PGH by Professor Emeritus of the Philippine College of Medicine of UP, Dr. Lourdes Ignacio. From her study, she mentioned that approximately 28 million people, Filipinos, would have mental health concerns or problems when the country's population hits the 110 million mark. So more or less, parang ganon, no? More or less 20% pa rin. So more or less, it's the same. And from these numbers, the 20%, look at this, depression and suicide among Filipinos. It's about, if we compute it, diba, it's about 3.3 million Filipinos would have depressive disorders or symptoms of depression, and it's closely followed by 3.1 million Filipinos with anxiety disorders. And what's also alarming is that studies have shown that there has been an increase in the prevalence of mental health problems through the years, with an alarming increasing trend of suicide among the youth. Grabe, na? So, my talk kasi is focused on the youth, the college students, and following the biopsychosocial approach in the understanding of depression, we know that there are several factors which may contribute to the mental health concerns among our youth, and some of the biological factors would include genetics, brain chemistry, diba? Yung mga neurotransmitters in the brain, life experiences, as mentioned earlier, experiences from childhood, from the formative years, such as trauma, abuse, family dynamics, and of course, biopsychosocial availability of social support, which is truly very important. Now, focusing on depression, we know that we can feel sad. Diba? Sometimes, sino dito ang never pang nalungkot, diba? Because sadness, we know, is a normal reaction to life struggles, setbacks, disappointments. We can feel, diba, sadness, lungkot. When we say anxiety naman, it's worry, pangamba, takot, no? Because of the uncertainties in life. Kasi if we do not feel these emotions, then we might be aliens, di ba? Na incapable of feeling any emotions. Baka alien tayo. Now, how do we differentiate sadness from depression? When we say depression, it's really different from the normal sadness because, number one, it now affects our day-to-day activities. It interferes, diba, with our ability to study, to work, to do activities of daily living. It can also affect our interpersonal relationships. And of course, it is intense. It can be intense. No? The negative thoughts can be intense and persistent. Tuloy-tuloy. No? It's not yung, when sadness kasi, by sadness, it's up, down, or our mood lifts when we feel better already, or when the stressor is addressed, etc. With depression, it is persistent. It's tuloy-tuloy. And when, di ba kanina I mentioned about anxiety and depression, let us remember that there is a high level of comorbidity between anxiety and depression. Usually, both are defined in terms of negative emotional experience. So something happens. Now, there is a negative source of stress, which may trigger the onset of symptoms of anxiety and depression. And usually these are something very stressful to the individual. Let's look at the overlap of anxiety and depression. Take a look at this. Oh, diba? It's quite high, na? For any mood disorder, be it unipolar depression or bipolar depression or dysthymia, etc., the other forms of depression, it's about the overlap is about 30%. Pero if it's clinical disorder, clinical depression, the major depression, ang taas, it's almost 60%, no? Ang overlap between depression and anxiety. That's why it's highly comorbid. And do you know that because they are highly comorbid, pareho din, no? In terms of the biological factors, diba? So neurobiology-wise, they share the same neurotransmitters, all right? So more or less, the same neurotransmitters are affected in the brain. So there's an imbalance of these neurotransmitters, serotonin, norepinephrine, dopamine, and as well as, again, as mentioned earlier, it can be precipitated by stressors, and they may show more or less. There's an overlap also of signs and symptoms, be it physical symptoms, behavioral symptoms, cognitive symptoms, and other forms of manifestations as shown by this figure. O, di ba? Parang more or less, ang laki ng overlap nila. Kaya it's highly comorbid. When we say depression, the core symptom there is bagsak ang mood. All right? So low mood or loss of energy, loss of interest in things now which previously were very interesting to the individual. When we say anxiety naman, yung pangamba, takot, there is that anxiety, worry, which is excessive. That is the operative word there, excessive worry or fear or anxiety about things which may happen, be it a threat or be it perceived, etc. And they have similar symptoms na nag-overlap, be it the cognitive. So both can present with cognitive symptoms, trouble in concentrating, focus, making decisions, worry, and agitation, and some physical symptoms as well. All right, now let's focus on, that's the intro about depression and anxiety. Now let's focus on depression and college students. College, diba? Usually pag college now, I think they are in the ages of 18, usually 18. But for those who were not, I think, accelerated or who were parang who started college early and they were not included in the shift to K-12, usually 16, diba? Yung college. In our clinics, diba? In your clinics, I would like to empower you to be able to recognize patients or college students who may be presenting with symptoms of depression. So we follow the criteria for major depressive disorder as enumerated in the Diagnostic and Statistical Manual of Mental Disorders version 5. So if you can see from here, it's really specified that there should be 5 or more of the symptoms, but the core symptoms, 2 core symptoms should be depressed mood, bagsak ang mood, as observed by others or feeling of the individual. And the other core symptom is diminished pleasure or interest. Nawawalan ng gana or interest to do the things which previously were very enjoyable for the patient. And other elements of the criteria would include, again, there's an impairment in functionality. It causes impairment in performance, functionality, productivity. It's not attributable to any other substance. It's not due to a substance or a medication. It's not a side effect of any medication, not explained by any other psychiatric conditions, and there has been no manic episode. Yung sa bipolar, di ba? As mentioned kanina, there's depression and manic. Now, let's take a look at some of the studies about depression in college students. Again, di ba, talagang it's the magic word, no? 1 in 5, again, 20%. Studies have shown that anxiety and depression are the two most common types of mental illnesses among college students. 1 in 5 have reported symptoms of anxiety among college students, and about 15%, so close pa rin, no, to 20%, have reported symptoms of or were treated for depression. Usually, just be careful kasi maybe in your clinics, they would report it as feeling overwhelmed. Parang ang daming iniisip, no? Overthinking, overwhelmed, feeling of exhaustion, fatigue, loneliness, sadness, hopelessness, all right? So they may phrase it or they may express it differently, no? Not in the manner na as stated kanina in the DSM-5 criteria. And definitely it can look different in teens. Na? So they may present with, instead of feeling sad, they may present with irritability. Palaging galit. Parang daming galit sa mundo. No? Parang ganon. Behavioral problems, drug use, substance use, sexual promiscuity, of course, decline in their academics, so they can have academic problems, preoccupation with morbid themes. Sometimes they post on social media mga posts about morbid stuff like I want to go, I want to just go away, leave. Heightened expression of boredom. They feel bored, and frequently they would have aches and pains which are unexplainable. So sometimes masakit ang ulo, and then the next day masakit ang likod, neck pain, back pain, knee pain, stomach pain, chest pain, mga ganon which are unexplained. And do you know that there's a science behind depression? As mentioned earlier, may science, ha? It's backed by, again, biologically, there are neurotransmitters involved, as mentioned earlier, and genetic component. Imaging studies would show that for a patient who is showing symptoms of depression, there is not much going on. No? Kasi nga, again, cognitive processes are slowed down, and it doesn't light up so much as compared to one who is not depressed. Psychologically, life events and depression, there's a positive correlation between stressful life events and the onset of depression. Usually, the most depressogenic are losses. Now, losses, meaning, lalo na pag sa mga college, breakups, di ba? That's a form of loss. Now, be it real or perceived losses. Breakups, loss of health, di ba? Or there's a threat to one's health, income for those who are also working. And as mentioned kanina, Dr. Sigua, kaya I'm so happy that it was mentioned among college students, among the youth. This has been one of the factors affecting their mental health and causing symptoms of depression and anxiety. It's social media envy. Alam nyo ba yun? Siyempre, the more time spent on social media, there is what we call as the social comparison theory. Na we compare ourselves from the posts of our friends online. No? So when we see their posts, there is that feeling of FOMO, fear of missing out, and then we compare na, ay, bakit siya? She's on vacation and me. So it can lead to symptoms of depression or sadness, low self-esteem, and other factors as mentioned also, like, of course, family history. So we really go back to the anamnesis, which is the story of the patient, and other major changes can also be risk factors for depression. Ano kaya? What do you think is the very concerning na major change now it's brought about by this current pandemic, and it's learning through distance. Now, distance learning for our students, college students, we know that distance learning is the new normal now. And because of this, it can pose challenges as well to students during this time of pandemic, changes in their routine, diba? So some would opt na muna na to enroll because of difficulty with the shift to online classes. There's also break in continuity in healthcare, missed significant life events. Di ba ngayon, no? We can hear na, oh no, parang I miss attending my graduation, JS prom, ano pa ba, like other parties, etc. And of course, safety. Again, there is a threat to one's safety and security. And a new phenomenon now during this new normal for our students is Zoom fatigue. And it has really been shown as a new phenomenon now, which is causing stress as well to students. And I think not just to students, pati na rin tayo who are continuously, there is this use of video conferencing platforms, which in the end can cause fatigue. So studies have shown, in fact, that depression and anxiety during this pandemic, and the population for this study is among public university students. And this study showed that the levels of depression and anxiety symptoms were higher, sobrang taas na, than those documented among the university students before COVID-19. And look at the numbers, mild and moderate symptoms of depression. So this was published, and this is an international study, but I'm very happy that in the Philippines, we have our own local study. This is authored by, again, one of my supervisors in PGH during my training, Dr. Anlakan, as one of the researchers, collaborators for this study, which looked at the psychological impact of COVID pandemic. And it showed, again, depressive symptoms, anxiety levels were quite high, stress levels, especially among, look at this, female genders, young age or the youth, which would include mga college students and young adults, students, yan na naman, students, prolonged homestay because currently we are in community quarantine, and so, and all of these factors, in fact, have an impact on stress, anxiety, and depression levels. And another study, this is an international study naman, looked into suicidality, and it was published last year in 2020. So in this study, it showed that epidemics may be linked to increased suicide rates, and that stressful life events are a risk factor for adolescent suicidality. So doctors, in your clinics, what can we do? What to do? Dr. Sigua mentioned or asked me to discuss about this quite quickly na lang kasi I know we are pressed for time. Screening tools, there is a screening tool which is very useful. You can use this in your clinics, Hospital Anxiety and Depression Scale, or the HADS. It's a self-reporting questionnaire with very quick lang to. It has 7 questions for anxiety, 7 questions for depression, and this is in fact a validated tool. And it can look into the severity and caseness of anxiety disorders and depression for all, for somatic, for those presenting with physical symptoms, as mentioned earlier, primary care patients, and general population. So this is an example of how it looks like. And the patient just has to tick, tick, tick. Diba? Tick lang nila, and then there's a scoring below, and then you add it, and then you can look at the interpretation. This is downloadable. Now, as mentioned earlier, there can be unexplained somatic symptoms among the young, diba? Kasi they may present differently kasi, yung pain which is palipat-lipat, na unexplainable. You can also give this to them. It's a somatic symptom scale to look into the types of pain which they may be experiencing or having. And there is also a recording, a cut-off score for this, and you can refer to this cut-off points to determine the severity. All right. So after screening, let's now move on to the biopsychosocial approach in the management of depression in your clinics. Kaya nga, I want to empower you. You can do this in your clinics after the assessment, because we know that in any public health response, mental health and psychosocial support is an integral component. Kasama lagi po ang mental health. And that's why I'm really glad that we have this collaborative na activity tonight. So, first, again, biopsychosocial. So biologically, we can address the neurotransmitters in the brain, as mentioned earlier, serotonin, dopamine, norepinephrine, by giving medications to give that stability of the neurotransmitters in the brain. So usually we give SSRIs, selective serotonin reuptake inhibitors, or serotonin norepinephrine reuptake inhibitors. So we have that. And of course, as primary care physicians, IMs, GPs, FAMEDs, you can prescribe it, all right? Because it doesn't require any S2 or it's not PDEA regulated. So biologically, what's next is psychologically. Psychologically, we do psychotherapies. Usually for those with depression, we do cognitive behavioral therapy to correct their thoughts, their negative thoughts, and mindfulness-based cognitive therapies and other forms of therapies, including family therapies. We also do that if necessary. Please, in your clinics po, if someone approaches you and talks about anything related to mental health and feelings, emotions, these are some of the things that we should avoid saying to them, What not to say, my dear doctors? It's just a phase. It's just a phase. Matatapos, mawawala. You'll snap out of it. Or stop being so selfish. You're just trying to get attention. Get over it. Let's not say that. Let's remember again that depression, anxiety are all true medical problems which warrant medical treatment, diba? Sometimes kasi it's so heartbreaking in my own practice to hear sabihin, depressed? Ay, Diyos ko, doc, excuse lang niya yan kasi ayaw niyang pumasok sa school pag umaga. Diba? We know kasi from the criteria as presented earlier that a loss of energy, bagsak ang energy, is one of the symptoms of depression. Anxiety, nagpa-panic attack, ay, hinga ka lang, you'll get over it. Or panic attack, ang OA mo, girl, just relax. Hindi po ganon. So let's avoid all of these unnecessary comments po. Let's all be non-judgmentals as doctors. Of course, we are here to help, to heal, and to give comfort to our patients. So what can we say? I'm glad you told me and I want to help. I'm glad you told me and I'm going to find someone to help you. If you need to refer to a psychologist, psychiatrist, then of course you can always refer to us and I will stay with you until help arrives. All right? Definitely, as doctors, all of us, diba? It's our duty to protect and save lives. So let's always make sure that our patients are safe. Safety is the priority. So let's inquire about suicidal thoughts, intents, plans, or attempts. Suicide risk assessment is very important. If your patients mention anything about having negative thoughts, self-harm thoughts, feelings of hopelessness, worthlessness, etc. And these are some of the risk factors for suicide. Usually male, young or the elderly with symptoms of depression or history of being diagnosed with depression, previous attempts of suicide, alcohol intake, impaired reality testing, yung mga psychotic with hallucinations, delusions, poor social support, planning. There's planning already on what to do. Again, poor social support and with medical problems. And if there is an imminent and clear threat of danger to oneself or to other people, please, as doctors, let's take reasonable personal action or inform responsible authorities, diba? Kasi of course, we are here to save lives. So let's keep our patients safe. Remember, as college students also, we can definitely reach out to their schools. I'm sure sa mga schools nila, they have health services, they have guidance counselors, they have psychology, and psychology services, na? Like in, yeah, no? So there are a lot of help available for our students. Of course, family support is very important, clergy, the church, community, etc. So marami po, there are a lot of support available. But for emergencies, please take note of the number of the National Center for Mental Health DOH, na crisis hotline. This is available po, open 24 hours a day, 7 days a week, and of course, confidentiality and privacy is always maintained. And with that po, maraming salamat, and I hope that I was able to empower you to be able to properly assess and treat or give management, appropriate management to the college students which you might see in your own clinics. Maraming salamat po. Thank you.
Thank you very much, Dr. Rifarial, for your insightful and empowering discussion on depression and anxiety among college students. With that, let me now introduce our last speaker this evening, Dr. Edgardo Juan L. Tolentino Jr. Dr. Tolentino had his medical degree at the University of Santo Tomas, his residency in psychiatry at Makati Medical Center, and was the chief resident. He is also a lecturer at Ateneo School of Medicine and Public Health, an international fellow of American Psychiatric Association, the founding and acting member of the International Society of Addiction Medicine, the past president of the Philippine Psychiatric Association, also the past president of the Group for Addiction Psychiatry of the Philippines, and now the chairman of the Department of Psychiatry and Mental Health at the Quirino Memorial Medical Center. Let us all welcome Dr. Edgardo Juan L. Tolentino Jr.
Good evening, everyone, and thank you, Christelle, for that very kind introduction. I'd like to share my slides. I'll do a deep dive kasi sa na-cue na tayo ni Dr. Rifarial that lots of us are actually undergoing Zoom fatigue. Kaya eto na ako. I shall lessen the fatigue by going straight to the point. Let me just state where I'm coming from. So from the talk of Dr. Sigua, she gave the world and how we could, with mental health professionals as well as the family physician, join forces in being able to address mental health in the different levels. Now, talking about those levels, na focus earlier ni Dr. Rifarial, yung young adolescents from college students. Now, I'm going to focus more on treatments for depression and anxiety in young professionals. So when we talk about these treatments, really nag-evolve na po yung definition of treatment success. What we now know as remission, which is the eventual goal of all treatments, started off in the 70s just as a response, which was the goal. But response merely means a reduction of symptoms using by 50%, using, for example, either MADRS, Montgomery-Åsberg Depression Rating Scale, or the HAM-D, Hamilton Depression Rating Scale. Then, 2 decades after, this evolved into remission. This becomes a little closer, whereas we have 50% then, now following still the MADRS and HAM-D, the score for MADRS is at least 10 and below, and for HAM-D, it's 7 and below. Still, that definition means that patients still persist with some symptoms. So enter our where we are right now. We have moved further into really making sure that our patients, we're not just counting symptoms, but mind you, make sure that our patients have full functional recovery. And with that, symptoms are practically absent and patients are back to their pre-morbid state. So here, obviously, we just ask our patients, is this what you used to be? But also, I will present in a bit some of the scales that have been developed to measure this a little more objectively. Now, I'd like to share with you, if you talk about any treatments in for depression, this will often be cited because the STAR-D, or the sequence treatment alternatives to relieve depression, happens to be the largest prospective clinical trial of major depressive treatments, which was conducted round about 2000 to 2004. It's actually a real life study, and it involved 2,876 patients with major depressive disorder. And this happened in primary care setting as well as psychiatric settings. Now, of these patients, 80% had chronic or recurrent depression, which is in a way the reality in depression treatment. With just the first line of treatment, so this was being followed sequentially. With first line treatment, you only get a 47 treatment response, and by that, of course, it was like it was defined before. We're just having 50% improvement, and in this case, the outcome measure was the QIDS SR, or the Quick Inventory of Depressive Symptomatology, the self-report questionnaire. For remission, okay, first line treatment, it was only a third of patients remitting with the first line of treatment. Therefore, that's practically saying that two-thirds of the patients still did not improve. So if we follow them through, this is the cumulative improvements based on the different steps. So with step one, you could see 49% of response and 37% more or less of remission. That didn't improve with citalopram or that was the step one. With step two, they would have been either switched, or there could have been a switch to, let's say, another SSRI as an SNRI, or cognitive therapy was added, and it improved just a little more, with 29% of the remaining with response and 31% with remission. With step three, that meant either switching to mirtazapine in this case, or something that we don't have, nortriptyline, or it was an augmentation to lithium and or thyroid treatment, and that only improved further in terms of 17% in response and 14% additional for remission. And with step four, where you have already major combinations, switching to a combination of mirtazapine and venlafaxine, etc., or already MAO inhibitors, which we don't have in the Philippines, then response further improved by 16% and remission by 13%. So what you could see here, and the important message here, is that for the most part, we will probably not have or fix it on the first medication that we choose. The lesson being that I think it is best that we choose the best possible treatments from the get-go. Further, if we look at, and this is the important thing when we treat depression, and that is to make sure we bring our patients back to functional impairment, which is the new goal in the treatment of depression. And at diagnosis, 68% of depressive patients actually have impairment in their, who are severely impaired. And add to that 23.6% who may be significantly impaired. You add those two and you have 92% of patients who do have functional impairment, which we actually will result into dire consequences, particularly in workplaces or skills. Now, this clearly was objectively measured in this particular study using the work and social adjustment scale. Only the minority, which is 8.3% of these depressive cohort, did not have any functional impairment. So the majority actually did. Now, looking at this meta-analysis, uh, now I'll introduce Lundbeck's newest antidepressant. In this meta-analysis, they looked into Brintellix or vortioxetine in terms of improvements in all the symptoms of depression amongst adults, making use of the MADRS, the Montgomery-Åsberg Depression Rating Scale. This is a meta-analysis of 11 controlled studies, which were short-term from 6 to 8 weeks. And despite that, you could see that there was improvement in all the 11 measures within the MADRS, and whether they are orange, 5 milligrams, blue-green in 10 milligrams, and the dark blue in 20 milligrams, you could see that there was significant improvement. But further, you could notice that the higher doses actually gave better and more significant improvements over that of the lower doses. Now, as we move on, also anxiety, and this is the nice thing about this particular medication, it not only treats depression, but depression with anxiety as well. As highlighted already by the lecture of Dr. Rifarial, there is significant comorbidity between depression and anxiety, with as much as 50 to 60% in community samples. And in this, which is rather moderate to severe depression, anxiety rather, using HAM-A, you could see that compared to placebo, patients who are on vortioxetine at 5 and 10 milligrams already started improving from the second week. Okay, particularly for our patients. And from the third week on, all the drugs, venlafaxine, Brintellix 5, and Brintellix 10 improve until the end of the study. Now, just mind you, venlafaxine was just included, but this is at very high doses. If you are aware, the venlafaxine in the Philippines is available only at 75 milligrams. If you double that, that's about the time that that's the only time it becomes an SSRI. But look at the dose here. It's more than triple that of the available dose in the Philippines, compared to only the basic doses of Brintellix 5 and 10 milligrams, as you could see. And yet, Brintellix, even at 5 and 10 milligrams, fared very well at third up to the end of this study. Further, here we very important also is that for both depression as well as high levels of anxiety, in another study, okay, making use of MADRS from baseline up to week 8 with as much as 604 patients, you could see that compared to placebo, this is at higher doses, and this is now using as a reference drug only. So it wasn't really in the study per se, but used as a reference. Duloxetine at 60 milligrams per day compared to Brintellix at 20 and 15 milligrams. And as you could see, in terms of depression with anxiety, there is already significant differences compared to that of placebo right off until the end of week 8. Now, very important also is to look at cognitive function. When you look at the 3 dimensions described by Dr. Rifarial of the dimensions of the symptomatology of depression, we have the emotional, we have the physical, such as the sleep problems, appetite problems, the other physical issues. And then we have the third, which is perhaps the one with the biggest implication on functionality, and that is the cognitive symptoms of depression. And this is important, as you could see here. Um, we have a drug which is bar none. And for the current state of science, we don't have any drug that directly affects the cognitive function of patients with depression. This is a new field of study only in the last couple of decades, perhaps in the last 2 decades, wherein they now have been focusing on the cognitive symptoms or dimensions of depression. And very important because that is, in fact, the one with the biggest impact on functionality of our patients. And therefore, emotional symptoms will improve first, followed by, in most studies, the physical symptoms, and finally by the cognitive symptoms, using most of the existing antidepressants. But with Brintellix, it's been found by different studies that it has already a direct effect from the get-go on the cognitive symptoms. And this study actually shows that, looking at the standardized effect size relative to placebo of the different antidepressant classes first on the left. So here is Brintellix versus placebo, and you could see a much bigger effect size. So this is not just significance, but really looking at how much effect it has on, in particular, cognition. And what used to be the standard for cognition, which were the SNRIs and specifically duloxetine, is just, has an effect size just a third of that of Brintellix. And you could see not much effect size for the SSRIs, the MAO inhibitors, which we don't have here, and what we learned in med school, which are the tricyclics. And the tricyclics, in fact, because of some of their side effects, particularly sedation, etc., may in fact impinge on our depressed patients' cognition. If we just break it down to individual antidepressants, you could see Brintellix still has the greatest effect size, and duloxetine comes only at a third of the effect size of Brintellix, and so on and so forth, with sertraline, the only one amongst the SSRIs, and so on and so forth. This is really something of interest because, as I mentioned, cognition will eventually have its effect on the day-to-day functionality of our patients with depression. Okay, so really, it will, if we improve the cognition, eventually we will improve the functionality of our patients, as shown here in this particular study. And here they made use of something more practical, the UPSA measure of everyday functionality. UPSA standing for the University of California in San Diego. This is the performance-based skills assessment. And let me just first walk you through some of the things, because this is a very adaptable test, if I may. These are some of the things that we actually look out for. For example, Patients are asked in the household chores to list down some of the shopping lists that they might do from day to day. Obviously, when one's depressed and with cognitive dysfunction, they may not come up with a complete list. Or if you ask them, give me a shopping list for the recipe of, let's say, adobo. Okay. And if they're used to adobo, they may not have the complete list. How about communication? You could ask the patient, and in the UPSA, what the patient is asked to do is to make a phone call, perhaps, okay, call your doctor and make an appointment for, let's say, Wednesday, June 9, and around this time. Okay, so this has a lot of complex skills that they should remember the number, whom to call, etc., etc. How about finances? You could actually have some play money, and you could give them, if I gave you this and the amount that I'm buying is X number, how much change do I get? And also, you could also ask them, I'd like you to pay the phone bills for this coming month. It amounts to so and so. Can you show me with the play money? With transportation, of course, in the States where this was done, you have a regular, let's say, bus or train schedule. So the one doing the assessment can give them the bus schedule. Okay, bus from here to here will leave at this time. Now, this is your destination. How do you plan to go to your final destination following the bus schedule? So very, very practical. And finally, for planning recreational activities, the patient can be given, for example, okay, there's this playground, let's say in this particular city near the hospital where you go to. I want you to plan out an activity for your co-patients, okay? And tell me, what should you bring, what day, etc. How do you get there? Very, very practical things. So down to the treatment, and they made use of this, and some patients were using placebo. There were patients on Brintellix either at 10 or the regular dose or 20 milligrams, and patients on duloxetine. And as you could see, duloxetine patients were no further than placebo in terms of the self-reported cognitive improvements through treatment. And you could see that significantly beyond those two would be Brintellix from 10 to 20 milligrams. So we move further. These are some of the advantages of Brintellix. There is no dose adjustment needed for renal impairment nor for hepatic impairment. For the elderly, the suggested dose is to start at 5 milligrams. And for your patients with some cardiovascular problems, there will not be problems either for cardiovascular functioning, either with QTC prolongation, which happens in some antidepressants, or with ECG difficulties. And I know you are family physicians, and you would like to choose medications which have the least of the drug-drug interaction. And as you could see, Brintellix has very low or practically no potential for drug-drug interaction because it does not inhibit CYP1A2, 2C9, 2C19, 2D6, which a lot of antidepressants actually also inhibit. So you have to make sure of that, as well as 3A4. This is a relatively safe but very powerful antidepressant. And with regards and of course the tolerability issues, I'd like you to focus on the last drug here, which is Brintellix, and these are the lists of the different side effects. And you could see the only thing that is from 10 to 29% of side effects is nausea. The rest you could see would be clear, showing that it is a very well tolerated antidepressant, which is good also for anxiety. And it is weight neutral, so it doesn't cause weight gain. I would choose this, for example, for female patients who don't want to gain too much weight. It has low withdrawal rate and discontinuation symptoms owing to its long half life of around as much as 66 days. So it's very safe when you are already ready to stop the medication. Very important too, especially amongst male, depressed na nga sila, tapos sexually problematic pa because of the medication we give. Well, for vortioxetine or Brintellix, sexual dysfunction is at a placebo level. So that's very encouraging. It doesn't cause sedation, which is important because remember, we want our patients back to full functionality. However, this is interesting. Patients who are on Brintellix actually describe their sleep as deeper. It doesn't make them sleepy, but once they sleep, it is actually a deeper sleep. And the most common side effect that we will find, just like practically all serotonergic agents, whether SSRIs or SNRI, would be nausea. And that is really a very serotonergic effect. As I already showed you, very low rate of safety related adverse events, low rate of treatment emergent adverse events, and low potential for drug-drug interactions. Now, again, and I just want to put this study because this actually shows how Brintellix actually works in terms of improving cognitive function, and not only cognitive symptoms, but how that translates into full functionality amongst our patients. This is introducing the at-work study, assessment in work productivity and the relationship with cognitive symptoms in patients with MDD treated with Brintellix. This was by Choka et al. This is an interventional open label Canadian study. Question number 1 was, does improvement in cognitive function result in increased work-related productivity in patients with depression who receive Brintellix in real-life setting? That's why it's open label. And the second question is, how does Brintellix impact on cognitive functioning in patients? Either there are two kinds of patients included here. Patients receiving treatment for the first time during a major depressive episode, and those who have been already started on another antidepressant but had inadequate response, and now you know the definition of response to the previous antidepressant treatment. So these are the so-called switch patients. Okay, for those patients with major depressive disorder who had inadequate response to treatment with one antidepressant at label doses, so that it's a fair comparison for at least 6 weeks. And then the opinion of the investigator is that treatment with another antidepressant is actually warranted. Okay, they are not treatment resistant. So this is just the methodology and the design. So they had to have currently an acute major depressive episode within the last 6 weeks, and then they are started with a first treatment, or for the first time, or they are switched because their previous treatment is inadequate. Okay, so this is screening and baseline. There will be a primary endpoint at week 12, and this is a planned interim analysis. And the primary outcome for this is the change of baseline at week 12 in terms of the perceived the PDQ, perceived depressive questionnaire, as well as a question of their productivity. And then they continue on until the end of the study, which is about a year after. And at this point, during the second period, which is the extension period, they can be switched to a higher dose of Brintellix to 20 milligrams. After study, they can be reviewed again, although this was not part of the journal yet or the report, at week 56 in terms of looking at their safety follow-up. And these are, allow me to present the results. So at the end, from baseline to week 52, you could see that these are the different measures that were used. Some of them are actually self-reporting, or most of them actually are self-reporting instruments or tools. So there, for depression, the primary outcome measure was with the QIDS, Quick Inventory Depressive Symptomatology. Okay, and that's here, and you could see that every time point from baseline, okay, blue green, to week 12, which was the primary analysis set, and the end of study at week 52, there was improvement in the depressive symptoms. In terms of work functioning, this was measured by the WPAI, work productivity and activity impairment, as well as the WLQ, which is the work limitations questionnaire. How about cognitive function? The perceived deficits questionnaire. This was originally used amongst patients with MS, multiple sclerosis, who obviously may develop cognitive problems as translating to eventual functionality. So it has been adapted also, particularly in the studies on depression, looking at the cognitive effect. How about overall functioning? We have the Sheehan Disability Scale, SDS, as you could see, constantly improving, as well as the WHO DAS, which is the WHO Disability Assessment Schedule. So in all these, it has been shown to be consistent in improving the depressive symptoms, the work functioning symptoms, the cognitive function, and it's all translated into better overall functionality. Now, this is further proof of the pudding, but in this case, we show also an assessment scale. Let me just introduce the DSST, which is the Digit Symbol Substitution Test, wherein at the beginning there are, I should have actually shown this, but the numbers 1 up to 9 are on top, and underneath each number would be a digit, okay, a symbol rather, that represents the number, okay? And the task of the patient is to, as quickly as possible, to substitute the numbers with the respective symbols. So this actually tests a lot of things. Obviously, you need to have working memory. You need to have speed in terms of processing. You need to make quick decision making, etc. So it measures several parameters in cognition. And as you could see, there was constant improvement in the DSST. And when it came to the perceived deficits, there was actually lesser of that deficit. In terms of the work limitations, you could see that there was, in terms of physical demands, mental and interpersonal demands, and output demands, there was improvement throughout the study until the end of the study. And as we saw earlier, with regards also the work productivity and activity impairment, there was improvement or lessening of those impairment. And look at this, and I'd like to highlight that the absenteeism part was highly improved due to the intake of Brintellix throughout this study. And just to summarize this, there was improved cognition, which was associated with improved workplace productivity in by the end of the study, concluding that as cognitive symptoms improve, work limitations also would decrease, making use of the WLQ, the work limitations questionnaire, whether significant for patients on first treatment, significant for the switch patients, and significant for the full analysis set. If we look further, um, here we could see that based on the DSST, the digit symbol substitution test improvements amongst the patients treated with Brintelix it helped relative to the normative means in the at work study. As you could see, these are older adults, okay? And look at the endpoint. When you combine all of these, there was a gap, okay, 15 points in the Brintelix treated patients. What does that mean? Especially, what is the implication? 15 years of cognitive function for Brintelix, it restored the performance from below the average score of the elderly adults age over 60 years. I removed the studies because my focus is on younger professionals to within the norm for the non-elderly patients. Imagine having a mean age now of 45 to more or less a younger age of 15 years, much younger in terms of cognitive function. What is the meaning of all this? Just to put it in terms of what is the closest thing perhaps to this? Well, the deficit in the DSST performance amongst patients who were depressed are actually similar, just so that we could imagine what it is like to have cognitive dysfunction in depression. It's similar to individuals with a blood alcohol level which exceeds 0.08. Now, just to put that in perspective, 0.08 is illegal driving or driving with impaired driving in the United States. In the Philippines, it will be pegged at 0.05. Okay, so even lower. And in safety industries, including Philippine Airlines, where I'm the psychiatrist, and in industries such as oil, etc., it is, you cannot go to work with a blood alcohol that exceeds 0.02. So you could imagine being depressed, it's 0.08. And at 0.08, you have depth perception, you have glare problems already, you can't see very well, you may have impairment in your peripheral vision, and you may already have problems in reasoning as well. So clearly, even in the anxiety symptoms, you could see that there is improvement, whether these are patients who were on their first, who were switched, or the full analysis set. There was a consistent mean change of improvement, and this was quite significant by the end of the study, which actually means as anxiety symptoms improve, when we correlate this, so that was measured using the self-report questionnaire, the Generalized Anxiety Disorder questionnaire 7, vis-a-vis work limitations questionnaire productivity loss, again, both of which are self-reported. As anxiety symptoms improve, the work limitations decrease, and those were all significant, whether patients were on first treatment, they were switched from an inadequate treatment, and if we combine the two. And as I highlighted earlier, patients with missed work days in the last 3 months, this is the comparison from baseline. As much as 55% of patients had missed days work, And by the end of the study, this was down to just 9%. Imagine over 55% of the patients at that time. So if we go by response and remission amongst just the observed cases, remember where we came from in terms of the biggest study, which is STAR D. We were just rather like round about a third of our patients, okay, going into response. Look at this. For patients on first treatment, 71% responded. Those on switch, 83%. And the total full analysis scale as much as 77%. So here we have 50, or rather twice that of what we saw amongst patients in the STAR D. And in terms of remission, again, very promising. For those who were started first treatment, 45%. Remember, these are first treatment. So this is the first time they have been introduced. But with patients who had been already on a previous treatment, there was 67% further improvement on those who were switched in terms of remission, which is practically not having any symptoms. And the full analysis set is half of